Okay, so I think we'll get going. I hope that you had the time to join the poster session and you are back from the poster session to the main Zoom link for the continuation of this workshop today. And we have a new session on learning health systems that leverage AI. And I would like to introduce Rebecca Grocco-Mishouris, who is going to be the moderator for this session. Rebecca is an assistant professor in the Department of Medicine at the Boston University School of Medicine, and she's also the Chief Medical Information Officer for the Boston Medical Center Health System. She does work in the role of technology and the use of technology in improving the quality, cost, and experience of healthcare. So Rebecca, the floor is yours, and thank you for organizing and coordinating this session.
Thanks very much, Yanis. And welcome to our next session here. I think this morning we had a couple of wonderful panels talking about potential of AI in healthcare and how we can mitigate the introduction of bias. And now we're going to hear how learning healthcare systems are actually leveraging AI and ensuring that we are mitigating that bias. I'd like to thank first my co-organizers for supporting the development of this session, Yanis Paskalidis, Heather Sue, and Michael Fishman, both from Boston Medical Center. And then last but not least, certainly welcome today's panelists. So thank you all three for joining us this afternoon. Our panelists will start with Dr. Irene Dankwa-Mullan, who is the Chief Health Equity Officer and Deputy Chief Health Officer at IBM Watson Health. We'll move on to Dr. David Bates, who's the Chief of the Division of General Internal Medicine at Brigham and Women's Hospital, and a Professor of Medicine at the Harvard Medical School and Health Policy and Management at the Harvard School of Public Health, and was my mentor when I was a fellow. And Dr. Leo Selly, who is the Clinical Research Director in the Laboratory of Computational Physiology at MIT, and a physician in pulmonary critical care and sleep medicine at Beth Israel Deaconess in Boston. Just a quick couple of housekeeping items before we begin. Just a reminder that today's session is being recorded and will be posted to the Hariri Institute's YouTube channel later this week. And we certainly encourage audience participation, and you can use the Q&A feature to ask questions throughout the session. I will be holding them until after everyone has gone through their presentations for our panel discussion at the end. The chat function is turned off, so please use the Q&A function. And with that, I will turn it over to Dr. Dankwa-Mullan.
Okay, well, thank you so much. Can you hear me? I just want to make sure audio is good. And then I will, awesome, share my screen. And I'm going to switch it to PowerPoint. This is good?
Yes.
Looks good, yeah.
Okay, awesome. Okay, well, first of all, I do want to thank the summit organizers for this opportunity. And really, I think it's a privilege to present at this important healthcare summit. Irene Dankwa-Mullan, Chief Health Equity Officer at IBM Watson Health, as well as Deputy Chief Health Officer. And what I do actually is provide leadership and health equity strategy to advance our IBM mission and goals for a culture of health equity, inclusion, ethical AI, and promoting technology for social good. So I provide subject matter expertise on clinical and science evidence, as well as evaluation around our technology. And at IBM, we support the healthcare industry and clients who deliver health and human services, leveraging our technologies to help drive improvements in health, not only in cost and quality, but most important in innovations and outcomes. So I sit within the IBM Watson Health Center for AI and Research and Evaluation, called the CARE team. And this center was created to evaluate and demonstrate the evidence and value of our solutions. And so what I want to do today in my presentation is to briefly touch on the current applications for the use of AI in healthcare. And then I'll discuss sources of AI bias. And I'll introduce a proposed framework for the design and development of AI across the continuum that we published recently, and offer some concluding thoughts. So hospitals, health systems, public health and health plans are all creating or co-creating and deploying artificial intelligence, machine learning applications on predictive analytics, image recognition, natural language processing on massive amounts of data or image points for actionable insights. And so I wanted to share this slide, which shows some of the various applications, both current and emerging in AI in healthcare. And there are several applications. For example, in preclinical research, we use an AI for drug discovery, for genomics medicine, and around efforts to advance the science of precision oncology. We also see AI and advanced analytics providing insights and establishing clinical pathways or informing treatment protocols and care, making predictions or stratifying patients in terms of risk for metastasis, for example, in cancer to guide treatment. There are also applications in the area of early detection of disease, screening, diagnosis. So, for example, using deep learning to digital images for prostate cancer, looking at pathology images for the detection and characterizations of polyps, for example, in colonoscopy screening. We also have current applications in population health, public health for identifying epidemics, right, and conducting surveillance and epidemiology and using AI on population-based data sets. And in certain places, we're also seeing it to optimize healthcare or cancer care delivery processes or other care delivery, such as procurement of drugs, ensuring chemotherapy, for example, or other drugs are delivered to the right place at the right time, and other logistics. And so before I begin, I would like to level set on two terms that I think are central to our conversation around AI, health equity, and health disparities. And I think definitions are really important. And in addition to definitions, the underlying values and principles when it comes to health and equity is even more important. So the issue of health equity and health disparities are deeply rooted in social values and those human rights principles that all persons should be valued equally. And so what makes health particularly important is that it's essential to well-being. It's essential to our ability to participate fully or contribute fully to society. And basically, ill health, sickness, or disease really threatens the ability of an individual to participate fully or contribute fully to society. So health disparities, as you see in the slide, are those unfair differences or particular type of health difference that is closely linked with social, economic, and environmental disadvantage. And achieving equity is the absence of these unfair differences. But I also want to use this definition of health equity that was used by my mentor and good friend, who I think is a visionary thought leader, Dr. Paula Braverman, and worked with the Robert Wood Johnson Foundation, and they basically define health equity that as everyone having a fair and just opportunity to be as healthy as possible. And this first slide, many of you may have seen it. You know, the first picture is reality, where one group of people gets more while the other group gets less than is needed So there's a huge disparity in the gap created. In the second figure, the assumption is that everyone will benefit from the same intervention or the same treatment. And it's sort of a one-size-fits-all approach without any consideration to the impact on other populations and the need to provide tailored interventions or resources or specific opportunities that would benefit everyone. And so instead, it's only benefit in one population and somewhat benefit in the other, but has no benefit at all to the third group. And the third figure actually described equity, meaning everyone gets the support they need. It implies everyone has a fair opportunity to achieve their full physical health, mental health, social health, and no one is disadvantaged, right, from achieving this potential. But we also, this slide introduces a term, health justice, where systematic barriers are removed, the structural barriers. And health justice is not only having those conditions and resources and opportunities, but also being empowered, right? Having that power to make those choices as well, without any bias, without any stereotypes, or even questions or resentment, right? Why one group may be getting more than another group. So I would like to take this opportunity to provide some context for the scope, the breadth and depth of bias, right? The origins, how it really becomes deeply embedded in our data and how it eventually leads to decision-making or interventions, and most important, resource allocation, right? And so I think it's important to understand the entire continuum or the process and the social, the policy, the ethical and legal implications, and identify opportunities where we can intervene, because bias is everywhere. It's not just in the AI algorithms or in our data. And there's several key or critical areas where bias is introduced and subsequently into healthcare. So the first one is, and I look at these as the 5 E's. The first is an evidence bias stemming from our research translation. And so we all know that medical and clinical decision is driven by an evidence base. So what makes up that evidence base for decision making? Who is defining what that evidence is or should be? And so for the most part, we know that evidence is really tied to rigorous randomized controlled trials. It's tied to studies, but basically and as well as pragmatic trials, clinical trials. And so if the evidence that we are looking at is lacking that real world evidence base, it's really an issue, and that's where bias can be introduced. The second is experience and expertise, which I think is really important. Provider expertise or their intention, whether conscious or unconscious biases, as well as the intentions, really make a huge impact on health and health outcomes. It's all part of human bias. I think it's also not just provider bias, but health plans, as well as the entire providers in the ecosystem and the full range, because they can provide options and they are the ones that decide on treatment options or care coordination for their patients. And so these recommendations, even from evidence-based clinical decisions, based on a synthesis of evidence summaries, including clinical studies, research trials, as well as clinical experience of the provider and expertise, may or may not introduce some of these bias. And so if these clinical studies or research or practice-based guidelines are not diverse, are not inclusive, we then again run the risk of perpetuating disparities in care. So provider expertise and their intention to address equity is really important. The third E is tied to data exclusion or exclusion of key information. If there is no aggregation on our data sets by race, by ethnicity, gender, disability status, or even social determinants, and other factors that we know are linked to disparities, linked to discrimination from healthcare, then it introduces bias. Data missingness, incomplete data in EHRs. We know EHRs typically favor those who have robust health data profiles. And so this is one aspect of a source of bias. Another is the environment. So have we considered the influence of social and economic environment? Those social determinants such as access to transportation or opportunities for access or optimal health. And so the influence of the external environmental factors are also important. But I think this fifth point, which is empathy, is also a source of bias. So how much the patient values, the patient's preferences are integrated as part of their care. And did the provider or the provider or the healthcare ecosystem really take into account or consider a patient's perspective or their circumstances? So data empathy is actually a lack of knowledge or experience about the people, the places, or the factors that make up the data, and an inability to recognize that bias. And this results in complacency or an inability to optimize our algorithms or our decision-making because there's lack of knowledge or context of the data sources or the real-world evidence. So there is this whole spectrum or continuum of data generation from research to design to development. And we really cannot separate these processes. Otherwise, we will box ourselves into narrowly focused interventions. So some key points that I wanted to make is that we have an opportunity to reevaluate the ways in which we can optimize our research in order to advance health equity. And I want to make these three suggestions. One is opportunities to address bias needs to occur along the entire science translation and technical development steps. Because in the research, for example, unless we developing better strategies and standards around how research is conducted, around how it's reviewed, how it's published, and disseminated into journals, right, with inclusive, intentional efforts to ensure diversity. And using all this information to incorporate into our AI-enabled decision tools in healthcare or into our predictive analytics, we will not be able to achieve that full potential of AI and machine learning to address health disparities. The second key point is we really need to integrate the complete etiologic context of a patient's health. Most of our current research practices around data reinforce norms of homogeneity among Black communities, among Hispanic communities, Indigenous, and other communities of color. And so we often apply similar standards and comparison in research between white and Black versus white versus Hispanic populations. But we know that all these population groups have different features. They have different risk attributes that may contribute to their risk or outcomes or resilience. And so when we're developing our predictive models or our risk stratification with data, our approaches need to be more robust. Our approaches need to be more thoughtful and consider the fact that health determinants of disease are multifactorial. And so we also need to look at our fairness standards and select a real appropriate and relevant reference groups for comparison. We need to assure that our definitions of patient similarity in terms of features or the variables that we are pooling are most important for selection and for use, and are also appropriate, since different definitions of fairness or similarity can have different predictions for a given individual. So a key point here is to leverage potential of AI in healthcare and consider patient needs and values, consider lived experience or life course experience, and the relevant determinants of their health. And for some, they will include geography. Others, it would be racism and discrimination. And the third point is building a culture of responsible data and innovation around standardized data set with a framework for promoting ethical and trustworthy AI. And this framework should include establishing actionable principles of fairness, of accountability, of trust, and transparency. I wanted to quickly, finally, sort of share this slide. This was based on a recent article that we published. And basically, you know, the development of AI in healthcare should really employ a strategic approach that considers health equity, that considers social justice, and ethical principles in managing the data, the modeling, the training, the deployment from conception, you know, in design to implementation. And I wanted to share this whole, you know, AI presents a whole host of ethical challenges and concerns for society. And so as such, we need to be thoughtful or careful in our approaches to deploying advanced technologies. And this slide demonstrates the various dimensions of ethical AI. Each of these dimensions have ethical and social implications, and I'm just going to touch on a few. And so from the onset, it's really important to identify not just the public or health benefits, but also to understand whether there will be benefits for each population group and whether there'll be groups that may be disadvantaged by the AI. And if possible, look at the positive social and economic outcomes, not just health outcomes. So for example, in accountability in AI in general has meant establishment of effective governance and oversight. And at times it's loosely defined, but this should not only be limited to regulatory and governance, but social and ethical accountability, and to the goals and action of ensuring equity, acknowledging the values for those groups to which the AI tool may be responsible, promoting accountability to the goals and values of socially disadvantaged groups, so racial and ethnic population. And your stated objectives also need to respond to the needs of the communities for which they're designed to benefit.
Time.
And in terms of, hello?
Time.
Yeah.
Oh, yes, time.
Yes. And so in conclusion, we just need to ensure that we have equity-centered design thinking into our AI, in our advanced technology. And there's a huge potential. This is basically saying that it's a learning process for us all, but one, it should really allow us to ensure a culture of innovative AI, promote humility building, self-awareness of all our biases, acknowledge and basically address how we can co-create with our community and stakeholders for the benefit of everyone. So I'd like to thank you for listening, and I'm happy to answer any questions at the end of this session. Thank you.
Thank you so much, Dr. Dankwa-Mullan. And we will keep the Q&A open, and we'll address those questions when we get to a panel discussion at the end of the 3 presentations. So please submit any questions you have as we go along through the Q&A. We're going to move on to Dr. David Bates, who's going to discuss the implications of the digital divide in AI. So Dr. Bates.
Thank you. Okay, can you see my screen?
Yes.
Okay, great. So I think what I have to say will follow well on what Dr. Dankwa-Mullan just went through. And I'm going to talk about the digital divide and implications for artificial intelligence. So in some ways, this is taking a step back, but digital health equity is that everyone should have a fair and just opportunity to engage with digital health tools. And some of the most important ones are mobile health apps, patient portals, and telemedicine. And yet, we have abundant evidence that people are not able today to interact equitably with all these tools. The COVID-19 pandemic was a threshold event for organizations in terms of converting to telemedicine. Many organizations were stuck at 3 or 4% of visits being telemedicine. And then all of a sudden, when COVID-19 happened, we switched overnight to doing this all as telehealth. So the numbers of telehealth visits went up really dramatically. But if you look carefully, they did not go up as fast for minorities or people who were poorer. And another example of this is vaccine policy. In Massachusetts, early on, you essentially had to be able to access the internet to get vaccinated, and many people really struggled early on to get vaccinated. People who are older, people who did not speak English well, and so on. A key piece of legislation that I just want to underscore is the Unc Cures Act, which places a new focus on patient access to their data. And the goal of that act is to make healthcare more computable and give patients control of their medical record. The concept is that patients will be able to interact more readily with their data, for example, through portals and mobile apps. And ideally, that they would be able to shop for care by comparing costs, understanding possible treatments, and expected health outcomes. Of course, that really implies that people are able to use these tools. Now, this is a very complicated space. If you look at the industry, there were 300,000 health apps and about $7.4 billion in digital investments in 2019 alone. But if you look at how things actually go for diverse patients when they try to use these apps, you find out it is not so easy. This is some work that I did together with Dr. Urmimala Sarkar, who led this, in looking at the usability of commercially available mobile applications for diverse patients. And what we did was to take some apps. We gave them to 3 groups, 9 caregivers, 10 patients with depression, and 10 patients with diabetes. We gave them condition-specific tasks, like enter your blood glucose. And for entering their blood glucose, which is one of the most basic tasks you could ask someone to do, the completion rate was 43% without assistance. Now that meant that 57% of these patients with diabetes could not get the benefits of this. The key themes when we talked to patients were lack of confidence with the technology. They were frustrated with the design features and navigation. But to a person, they all said that they were interested in having technology to support their self-management. So this just suggests to me that we need to meet people where they are. Similarly, if you look at patient portals, 88% of primary care providers offered the ability to access health information online. But if you look at use, 31% of patients electronically actually did access their information online. These are data from Jorge Rodriguez in a study that was published in JGIM in 2020. And if you look at patient portal disparities, there are increasing disparities based on these factors, which are the ones that we've been talking about. So race and ethnicity, income, education and literacy, age, language, disability, and worst of all is being in a rural area. So there's a big digital health opportunity, and the design and implementation of health IT has the possibility to eliminate disparities, but for that to happen, it has to be designed with components that focus on the identification and elimination of disparities from the start, and these tools have to be tailored to the needs of diverse populations. One really basic thing is that 21 million people in the US lack broadband internet access. This is based on some recent data. And if you can't get on to the internet, it's really hard to get good healthcare in the US today. There's some work that's been done on screening for digital health equity, and there's some good tools for doing this. There are places that you can screen include at registration, integration into social determinants screening, or at discharge. And here are some examples of the kinds of questions to ask, like, do you ever go online to access the internet, like such as for online searches or to send or receive email, or to watch shows or movies online or use social media sites? And it's remarkable when you ask these questions how often people are not able to do some of these things. So let's transition to AI. The backdrop is that we already have huge inequities, especially in the digital space, and we have problems with systemic racism. AI is really good at prediction, but with the more complex techniques in AI, you can't explain how you got to the answer. And the net result of that is this tool could easily worsen inequities, which are already bad. And there's not a simple fix because there are many correlated variables. Here's an example of one of the AI techniques. It's the most powerful. It's a deep learning. Probably most people are familiar with this, but this was only accepted as being viable in 2012. And the way things work is you take digital inputs like image or speech, they go through multiple layers of neurons, and that's turned into output. They typically have between 5 and 1,000 hidden layers. This is a really powerful tool. It's better than humans in Go and Texas Hold'em, among other games. It's the main technology in self-driving cars. But the issues with it are that this is often not validated in the real world. And building these models requires having annotated data sets. It's also generally not possible to explain how you got to the answer that you reached, which is a challenge for AI. And there are some real practical examples of how this has caused problems. I'm sure Dr. Sully is going to give you some more, but this is a study that was led by Ziad Obermeyer, who found that millions of Black people were affected by racial bias in healthcare algorithms. Now, this study, which many of you are probably familiar with, was published in Science. And what it found was that this algorithm was less likely to refer Black people than white people who are equally sick to programs to improve care for patients with complex medical needs. There's some big efforts to try and deal with algorithmic bias. One has been led by the Brookings Institute. There's a focus on algorithmic bias detection and mitigation, and they've offered some best practices. And there's an entity called the Algorithmic Bias Initiative, which is focused on sharing research insights with healthcare providers, payers, vendors, and regulators to try and identify and mitigate bias in commonly used healthcare algorithms. But we desperately need to figure out how to make this routine. Another issue with using AI is how clinicians can use this at the point of care. And I'm not going to go through this in full detail, but for those of you who are in healthcare, I think it's a good piece. I did this together with Christina Silcox and Susan Denser, and we published in the New England Journal Catalyst in 2020. And we went through a set of things which AI should do to be useful to clinicians. So the kinds of questions that clinicians should be asking are, does this AI-enabled decision support software or system yield clinically important improvement compared to the status quo? If it doesn't, there's no benefit of it. Will this fit into my clinical workflow or my team's workflow? And then finally, what information does the decision support software provide at the point of use about the logic behind its decisions or recommendations that it produces? If we are going to get to digital health equity, there's some things that we need to do. This is a paper that I wrote together with, which was led by Jorge Rodriguez and Cheryl Clark. And we published it in JAMA in 2020. We made some suggestions around what governmental agencies should do, vendors should do. So for agencies to require, for example, future regulations and implementations of federal programs like promoting interoperability to include metrics that don't just look at overall use, but look at use by underserved populations. And in addition to expand federal mandates guiding culturally appropriate care, like the class standards, to be inclusive of technology-powered care. And finally, enacting policies that update broadband access use and increase the broadband access to patients really broadly. There are also a set of recommendations for institutions and clinical teams and patients. Institutions need to do things like invest and implement in-patient portals and mobile health apps that address the needs of underserved populations. They should also track digital health access and usage across sociodemographics and focus on patient training and the deployment of new technologies to account for varied literacy levels. And finally, to develop workflows that allow clinical teams to engage with diverse patients across digital health platforms like telehealth. And I'll close with this statement. You cannot tell a patient's likelihood of using digital health by looking at them. Thank you.
Thanks very much, Dr. Bates. It's certainly true. I don't think anyone would predict that my 105-year-old grandfather uses his iPad regularly to FaceTime his great-grandchildren. So we will move on to Dr. Leoselli, who will talk more about how we do better with AI than we can do without it. Dr. Selly.
Thanks, Rebecca. I'm going to share my screen. Okay, so the title of my talk is Better Than Humans, Building AI that is Less Prejudiced and More Fair. And before I begin, I would like to acknowledge that our group receives research funding from the National Institute of Health, as well as several industry partners. I represent MIT Critical Data. It's a consortium whose mission is putting data and learning at the front and center of healthcare. The consortium consists of healthcare practitioners, public health practitioners, computer scientists, engineers, and social scientists who believe that data and learning are the best medicine for population health. We build communities across disciplines to derive knowledge from data routinely collected in the process of care in order to understand health and disease better and in the local context. The consortium is led by our group at MIT, the Laboratory for Computational Physiology. Our flagship project is the MIMIC database. MIMIC stands for Medical Information Mart for Intensive Care. It was the first resource of this kind, developed and maintained by our group over the past 2 decades. The database is now in its 4th iteration as MIMIC 4. It contains high resolution and multimodal de-identified data from the electronic health records of patients admitted to the intensive care units of Beth Israel Deaconess Medical Center. The data include, but are not limited to, vital sign recordings, waveforms, laboratory data, clinical notes, diagnostic reports, medical images, and administered interventions, including medications. In addition to MIMIC, our group also partnered with Philips to release de-identified data from the Philips EICU Research Institute. The EICU Collaborative Research Database is a multi-center critical care database containing data from more than 200,000 ICU admissions from across the United States that were archived from Philips ICU telehealth platform. Long believing that open access to data spurs innovation and accelerates progress, our group makes Mimic and EICU CRD publicly available to any individual who completes a standard course on human subject research and signs a data use agreement. In doing so, these data have allowed for countless projects in academia and industry. And the availability of Mimic has made the Beth Israel ICU population the most intensely studied ICU cohort to date. In addition, the data use agreement for both data sets requires that the codes for the projects be publicly shared after publication. This has led to the rapid development of reusable concepts and their respective codes and queries in the repositories. The availability of this code accelerates research and promotes reproducibility by ensuring that common concepts are implemented consistently across studies. Across the world, we organize datathons, short for data hackathons, where we pair clinicians and data scientists to analyze real-world health-related data. Clinicians learn the nuances of data curation and model development, while data scientists are provided invaluable insights into clinical context and decision-making. The success of the datathon has relied heavily on the availability of data. The events would begin with clinicians from local hospitals pitching their research questions to the audience. Teams are formed and immediately get to work to parse the question into a study design, extract the cohort, and build models with the support and guidance of mentors from local hospitals and universities. And with the publicly available code repositories for our data sets containing many of the common concepts required for clinical research, projects can be rapidly performed in the span of a weekend. And we have hosted 38 datathon events in 16 countries across 5 continents, jumpstarting numerous international collaborations. And this have also shown to numerous decision makers the magic that is created when electronic health record data sets are given into the hands of as many expertise, as many experiences and perspectives as possible. And with Mimic as their inspiration, hospitals from the Netherlands, Korea, Spain, and Switzerland have made their electronic health record databases publicly available, and hospitals and clinics from Brazil, Uganda, Australia, and Chile are working with our group to do the same. I'm gonna start off and jump into our topic today by presenting a preprint publication that was released over the summer. And in brief, these were the main findings of this preprint. Artificial intelligence can trivially learn to identify the self-reported race on chest x-rays, on hand x-rays, on neck x-rays, as well as chest CT. And artificial intelligence learns to do this even when being trained for clinical tasks such as prediction or classification. This results generalized with successful external validation and replication in multiple X-ray and CT data sets. And despite many attempts, we couldn't work out what it learns or how it does it. It didn't seem to rely on obvious confounders, such as diagnosis or age or other cues that can be seen from the chest X-rays, nor did it rely on limited anatomical region or portion of the image spectrum. Why do we care that computers can identify sensitive attributes such as race, ethnicity, or gender, or other demographics for that matter, even when these information are scrubbed from data sets? That brings me to the story of Clever Hans. So Clever Hans was this Arab stallion from Russia who was bought by this retired schoolmaster known as William von Austin. And he taught Clever Hans how to identify numbers and perform simple calculations. And everyone was excited, people would watch them. But it turns out that Clever Hans wasn't actually performing the calculation. It was taking cues from the heartbeat of Wilhelm von Austin and the audience watching. So when they performed some experiments where they did not tell William von Austin or the audience the actual question, and so that they do not know what the answer is, Clever Hans wasn't so clever at all. He couldn't differentiate when to indicate whether the correct answer is being pointed to. And this is a perfect example when they seem to be doing a task that they're supposed to do, but the way they're doing it is not really what they are supposed to be doing. Are there examples of clever hands in machine learning? Absolutely. In this work from University of Washington and UC Irvine, the investigators trained a computer vision algorithm to distinguish wolves from huskies. All the images of the wolves had snow in their background, while none of the huskies were photographed with snow. And as expected, the algorithm picked this up and learned from the background and not from the animal features. This can happen too if computers can identify the patient race and use it for classification or prediction instead of the relevant features. 2021 marks the 5-year anniversary of the ProPublica investigative report on machine bias. But all we have accomplished since then is understanding how difficult it is to prevent AI from perpetuating societal biases in algorithms. When a sensitive attribute such as race ethnicity is learned, even when deliberately removed from a data set, then it is not far-fetched to think that algorithms will also pick up provider subjectivity and bias in decision-making. After all, algorithms are trained on data that document clinical intuition and judgment, encoded as decisions that contribute to outcome disparities across race, gender, and other demographic factors. These papers shown here demonstrate how gender and race concordance between the provider and the patients affect outcomes. For those of us in this exciting field of medical AI, we need to remind ourselves that data routinely collected in the process of care are heavily influenced by long-standing social, cultural, and institutional biases, as well as provider subjectivity in decision-making. Given the consequences of an incorrect decision, high-stakes medical AI algorithms need to be trained with data sets drawn from diverse populations. Yet, this is not happening. In a recent study published in JAMA, the investigators reviewed over 70 publications that compared the diagnostic prowess of doctors against AI, and most of the data to train those algorithms came from 3 states, California, New York, and Massachusetts. Whether by race, gender, or geography, medical AI has a data diversity problem. Researchers cannot easily obtain large, diverse medical data sets, and that could lead to biased algorithms. And from a global perspective, majority of the algorithms are being trained and validated on data from only a handful of countries, further reinforcing the tradition of a medical knowledge system that feeds into health inequities. Our group reviewed all manuscripts published in PubMed in 2019 that employed AI techniques. We then described differences in database nationality, domain specialty, and author nationality, sex, and area of expertise. The figure represents the country source of the database used to train and validate the algorithms. Only a handful of the countries are represented, with 40% of the manuscripts presenting models trained on dataset from the United States. AI research has divided the world into data-rich and data-impoverished countries. We need a better roadmap to leverage the value of machine learning and derive knowledge from the zettabytes of health data we collect in the process of care. But that roadmap is not easy to build. First of all, I would like to point out that it is not enough to make sure we are training and validating algorithms on diverse data sets. It is required, but it is not the solution to the problem that we face. At present, the most important evaluation metric for machine learning in healthcare is accuracy. But if accuracy is all we are after, and we use real-world data as ground truth, then we have no hope of fixing outcome disparities. I don't have the solutions to the problems I present today. However, I'm certain that algorithms developed by teams with perspectives that underrepresent most of the world are bound to maintain the status quo. We should not only invest in storage and compute technologies, federated learning platform, or even creating diverse data sets. Our goal should be to build capacity across populations and diversity of perspectives in research. This is the biggest investment we can make to prioritize equity. On that note, we introduced a new school of thought in research, village mentoring and hive learning. Our group has created an interconnected meshwork of experts, not just across countries, but across various cultural contexts. The network has developed into a web of students and teachers whose goal is to learn together and from each other. The problems we are trying to address: health disparities, a medical knowledge system that disproportionately represents a majoritized few, are the same problems we faced in the previous century. We cannot solve them with the same strategies that created them in the first place. The idea that a single group with a narrow range of skills can have an impact is both arrogant and ignorant. We need to break down the silos across disciplines, across populations, and leverage each other's expertise, experiences, and perspectives. And with that, I'm going to turn it back to Rebecca.
Thank you very much, Leo. And thank you also again to Irene and David. Maybe I'll have David and Irene turn your cameras back on, and we'll spend the next 20-25 minutes or so in a panel discussion with all three of you. To the audience who's been listening, thank you for your attention. If you have questions, please put them into the Q&A and we'll work them into this conversation. I think one thing that you all touched upon was how to translate all of this from research, from bench to bedside or computer to bedside, if you will, at this point, right? And there was certainly, over the last few years and even more recently in the last couple of months, there's been a series of articles and news media stories about how predictive algorithms work differently in the lab versus real world implementation, as do most clinical interventions, right? But for all three of you, how do we design pragmatic trials to really try and identify what those challenges are and provide guidance on how to mitigate those potential pitfalls as we go to implement AI in healthcare?
Does anyone want to start? I mean, I could start. What I'm going to say,
Leo.
I don't think we're ready yet. I don't think we're ready for pragmatic trials. I think we should really pause at what we're doing and understand better how to make sure that the algorithms that we develop do not have baked in them all the prejudice, all the bias, all the subjectivity that we have. And until we are able to fix that, I think we should not try to push this into the front lines of care.
Irene, you want to jump in?
I also agree. I think there is an urgent need, because AI is already at our doorsteps, of medicine. But I think we need to consider all the factors around what would be included in an equitable design and conduct of a pragmatic trial through conception, analysis, and reporting. And so what are the research questions that we want to ask? What is the goal, right? Is the goal for improved health outcomes, for improved health, or is the goal for reducing cost, right? As we realized in the study that Dr. Bates was alluding to, right? They were looking at cost. So I think that in designing it, we need to address some of these issues around the research questions, around how our science is being conducted. But I also think that it's larger than that. And we need sort of an organizational and leadership commitment to ensuring sort of, that inclusiveness and fairness and ethical AI from the design of pragmatic research to implementation of it. And so that's what I'll add to it. But I do agree.
Well, I'm going to disagree a bit. I don't personally want to wait. I feel like we should start to use some of these things and learn from our experience. And I don't think we'll get it exactly right out of the box. But a couple of things that I think could work in our favor would be to develop models at individual sites so that you're not taking a model that's developed at some other place and then force it into some new place and expect that it will perform in the same way. And second, develop approaches that allow algorithms to learn. If they can do that, that I think will be useful. I don't think that's going to ensure that we've dealt with all these other issues, but I want to see us make progress faster than we otherwise would.
Healthcare is not exactly a notorious for moving quickly with technology. So I would agree with that. One of our attendees asked this and is kind of, how do we know when we've reached the goal? How do we know when we've mitigated bias and addressed inequities in AI?
Well, that's a good question, and that's always asked. I think that you know, when basically we have, you know, I think when the opportunity is when everyone has a fair, we're basically not questioning the data. We're integrating health equity principles, social justice. The data is, you know, integrates, AI integrates ethics, transparency, accountability, and we have an opportunity to do that. And so it's when there is equity in the entire process. It's when we see a diverse, not just, you know, AI algorithm developers, diversity, but, you know, data scientists and the healthcare workforce. Because I think it's all part of, you know, the bias and the inequities we see in the data is deeply embedded throughout the institution. So we will achieve that when, you know, the outcomes are closing the gaps in health disparities, I should say.
I'd second that, and I think it's a question that I've struggled with too. I don't have an answer that I can give that I'm fully comfortable with yet. I kind of think it's a journey and not a destination. And we'll be working on this for the foreseeable future.
So I think
Yeah,
the biggest
and we may not always get it right.
The biggest problem is how do you evaluate these algorithms? Because really, it's all accuracy right now. And that's why people think that, oh, if we have diverse data sets and we represent every marginalized population, then the algorithm would be fine. And the answer is no, it won't be fine. Because the ground truth is bad. So if we keep predicting that this person will have a bad outcome, of course it's going to be accurate based on real world. But that's not what we want. So what we want is a prediction if the world were fair. And that's going to be very tough. So for example, in a bank loan algorithm, what if we can fool the computer to think that this person lives in another zip code? Would that change the decision? Because for this particular person, the zip code trumped all the other features in terms of providing a decision at the end. So again, machine learning community thinks that they could work this out by just giving them more data. And I think that we can't do that. We need to work with social scientists. We're working with some adversarial attacks on the data sets, adversarial attacks on the models to try to fool it. Like if this person were white, would this person be granted an interview? And don't say that, oh, we remove the race from the application, because we know that the computers can still figure out the race through the other data elements that are included in a data set. So I do agree that we shouldn't stop what we're doing. I think that we should focus our attention on how to fix the problem. Like I get so frustrated when I'm reviewing papers for large machine learning conferences, and they're all about improving accuracy, but we don't want accuracy. We want to come up with some counterfactual predictions and classifications and assume that everyone has equal access to healthcare. That's the only way we're able to prevent AI from just carrying on with all the disparities that we're seeing now. And I don't have the answers, but we're doing a lot of experiments on how to try to come up with algorithms that are not accurate, but are closer to the ideal world.
And so is the answer then, kind of following on that, that we should focus kind of immediate use of AI in certain areas that maybe are less risky than diagnostic or treatment? And what would those areas be? You know, if we take David's approach to just get going and learn as we go, where should we start?
we can start applying algorithms to white male individuals, and I think it's going to be accurate and there will be no problem. Well, the same thing with the
Yes.
whole of medicine, like the way we look at medications, the way we look at medical device, they're all centered around a majoritized view. And I think it's safe to use those medications for the target population or those who were involved in evaluating those products. And it's the same thing with AI. I think it's going to be safe to use them in the populations that are not marginalized and who were also, for the most part, involved in the development and validation of algorithms. And I don't have any problems with that, except that you're going to be widening disparities if you take that approach.
Yeah, I agree. I mean, I think the issue is we all have a huge role to play, and it's not just even in the healthcare provider community, but even purchasers of healthcare, right? If our care is not patient-centric, if we don't provide patients with a full range of treatment options or opportunities, maybe based on their health insurance coverage, or maybe based on bias or unconscious, bias, what treatment or that the treatment a provider gives or a doctor writes is what goes into the data or the medical, EHR, and that's what we will use. So I think we all have we need to have a collective shared commitment that purchasers of care, health plans demand equitable health benefits for all the patients. Doctors provide the full range of treatment options, but also the data, the evidence base that we're going on is inclusive, because otherwise everything is biased. And I agree. I mean, it just would not be applicable to all patients.
Yeah, I think that there are many areas that we can work on now. One is just administrative things. So if you do something with staffing, you can make things work better. Similarly for triage, putting people in the right level of care, finding people who are decompensating sooner. All those things are sort of relatively non-threatening.
And so what role does that interaction between the patient and the healthcare system, whether it's a provider or a registrar, or a medical assistant, what role does the interaction between patients and actual humans in healthcare play in mitigating bias in AI, right? If part of the issue is the bias in the data, but that data is collected by humans, how do we mitigate that data collection bias? And then, David and Irene both talked about, Irene called it empathy. David talked about how do we make sure that people are actually taking advantage of the AI recommendations that are being put forward, right? How do you then make sure that that interaction doesn't introduce an additional bias? If we were to get the AI right? If we could get the data collection unbiased and the AI unbiased, where does that human interaction then leave us? Because that can also be fraught with bias.
So and that's why I think we're introducing the trust and that whether there's a shared decision making that integrates the patient's values and preferences. I mean, I think they both have a huge role to play in mitigating bias. But I think the provider or the healthcare system or ecosystem even has a larger role to play. And there has to be sort of transparency and trust. And these are the range of options, and explaining to the patient, the use of their data as part of the AI, the clinical decision making, and how that would help benefit them. So yeah, I mean, I agree. They both have a huge role, but I think for us, it's the healthcare ecosystem even has a larger role to play.
Leo, you must have something to say on this topic.
No, I was reading the next question actually, but David, if you have any comments on that question. I was thinking my answer for the next question from Yanni.
Well, I was
Working ahead.
doing the same thing, so maybe I'll just work on the next question. So this question is from Giannis, who points out that electronic health records today capture medicine data for the medicine of today, so whatever is being done. And he's asking, is these the right data for the AI-enabled medicine of tomorrow? And I think, as he suggests later, the answer is almost certainly not. I mean, we can certainly do a lot better with predictions if we start using other streams of data. You know, with one example being data from your smartphone. People may or may not want to give up data from your smartphone, but it's been demonstrated that you can tell with extremely high degrees of accuracy, for example, whether somebody is depressed from basically from how you're using your smartphone. The way that you use your smartphone when you're depressed is really different. You make fewer phone calls, you send fewer texts, you don't move around as much. And, you know, we're going to have to decide, like, of all the data that are available about us, you know, what do we want to have accessible to these tools? Because, you know, we could definitely do better with prediction if we make more of it accessible. But there are many questions about privacy, for example, in terms of how far we want to go in that regard.
All right, Leo, what was your formulated answer?
No, I mean, I think Yanis pointed out that definitely there is differences across populations of how we collect data. We had a preprint that we published last week that even from vital sign recordings and nothing else, the computers can pick up whether a person is Black or white. So it turns out that we're measuring blood pressure more often from a white patient than compared to a Black patient, even after adjusting for how sick they are. So we are very paranoid now of how computers are able to do this, even if we think that, oh, we hid everything that can be used for an algorithm to be to create some bias. And it turns out that we're not very good at hiding things because there are other cues that the computers can learn from to determine sensitive attributes such as race, ethnicity, or even gender, or even demographics. And that's why we are very concerned that all the algorithms that we have now are probably inherently biased, and we have not done enough vetting. So one thing I think to push out there is that algorithms should not be looked at as a final product. Algorithms should be continuously monitored after they are implemented. And we're not just monitoring their accuracy. Once again, accuracy should not be our main rubric for evaluating it. We should be looking at the effect of the algorithm on disparities. If the disparities are widening, then we should stop the use of that algorithm because it's probably magnifying the individual biases. Suddenly it's at scale, it's being done across the institutions rather than a few healthcare providers. So to the computer science people out there, before you start doing your exploratory data analysis, try to figure out first too, how the data was collected. Like the patients in the cohort, how did they get there? Were some people excluded just because, like in an ICU database, were some populations dying before they could even reach the ICU? And what is the impact on that on the models that you're building using an ICU database? You have to know the baseline level of disparities that exist in that particular domain, because you're gonna be looking at that very, very closely when you start developing the algorithms, because I could assure you, spurious associations are very easy to capture in algorithms. And those are the parts, or those are the components that will perpetuate any inequities that we're seeing now. But it's a very, very complex problem. We would like to, this is a call for action. Please don't just try to focus on the next deep learning model to improve accuracy by 5%. We don't need that. We need to understand how biases are baked into this algorithm so that we could fix it.
Yeah, I agree. I mean, I think as you're all doing, we all need to do our part in our respective roles and responsibilities for ensuring, you know, a culture of responsible innovation, you know, integrating a framework of ethical AI and values principles of health equity into the models. And I think we could start trying and, learn from our mistakes and basically move on with achieving a good algorithm, right? AI algorithm that's transparent, that is, trustworthy and produces equity. So like I said, it's basically the outcomes, not necessarily the process or the accuracy of the model, but what are the outcomes? What are the social, economic, and ethical implications? And I think we all can strive to do better. I agree with Dr. Bates, David. It's health equity is a process, and we all want to achieve that. We all have a shared social mission.
I guess building off of that and Leo's comment, and I think it was David's comment earlier, that these are living, breathing things that really don't have an end, right? We continue to evolve them. What is your advice for budding researchers in this space to engage with interdisciplinary teams? Leo, you talked about your international think sessions, and how do we also ensure that we have a healthcare workforce that is able to understand these algorithms and how to apply them to populations and to individuals sitting in front of them as they go to treat these patients? Irene, do you want to take that first?
Yeah. In terms of having a healthcare workforce, I think it starts with, we can have a healthcare workforce, but if we still have, it's that, I think, definitely diversity, right? Research, increasing the research workforce diversity, addressing the stereotypes and conscious biases across the workforce with training, in introducing cultural competence. We all sort of need a level of health equity literacy or awareness about it, awareness about the biases that exist in our algorithms. And so I had said earlier, sort of our organizational and leadership commitment to that social mission of equity, inclusiveness in our clinical trials, and also making sure that, for example, we need, our designers and developers, they could, thoroughly and strategically consider, algorithmic fairness and safety risk, trying to have data that's at least representative. So all these, there's sort of strategies that we can integrate it into our daily work, but I don't think it's beyond just diversity in the workforce. It's about the individual and organizational commitment. It's your compassion and your, data empathy. I think it's where we want to achieve. And that's where that's what I'll add.
Leo, do you want to talk? Oh, go ahead, David.
Sure. I do think workforce diversity is critical. We're doing some work right now with IBM to help organizations better understand their workforce diversity. Turns out most organizations don't have things set up so that they can readily figure out how diverse their workforce is, and in which areas. People earlier said today, you want diversity really in all areas, and if you can't understand that readily, it's hard to pursue it. You also want tools to understand the diversity in your patient population and how things are going for different segments of your patient population. You want to be able to figure that out relatively readily, so you can figure out whether or not you're making progress.
One thing that I'm going to add is we need to start early And we need to remove the divide between research and operations, because for the longest time, healthcare providers think that research is an activity of academics, and they're there to, for the most part, be a passive recipient of guidelines and recommendations from professional societies. Our goal is to make every healthcare provider a contributor and a custodian of the medical knowledge system. There has to be accountability from everyone, and that requires complete transparency in how you're analyzing the data. But that mindset is not present among our healthcare providers now. For most clinicians, research is something that they're not interested in. And I think we lose because we're not taking advantage of the breadth of the experiences and perspectives. If only a handful of people who think alike, that's us academics, are the ones who are the caretakers and the custodian of the medical knowledge system. I think we need to do a better job of bringing in more people and being excited about contributing to the knowledge system. And that really starts very early on. I think trying to provide data science curriculum for residents and fellows is a bit too late. We are working with K-12 educators to try to see if we could introduce them to data science principles as early as middle school and high school. And I know that the country of Bhutan has introduced data science into their high school curriculum. So I think there has to be more concerted efforts if we are able to take advantage of all the data that we're swimming in now.
It occurs to me that in medical school, right, you're taught to take care of the patient in front of you, and no one really teaches you how to take care of a population or the importance of the data that you're collecting in order to take care of that population, right? And so the comment that we have to start early really can't fall on deaf ears, that this really has to be an initiative very early in education, and not just medical education either. As organization, there was a comment in this morning's panel that AI is here in healthcare, right? As imperfect as it may be, as biased as it may be, institutions are using AI algorithms in delivering care. And so what would you say to those organizations as they go to implement these algorithms in clinical care to most effectively and equitably harness what may be inequitable algorithms to try and achieve the quadruple aim of quality, cost, and both patient and provider experience? How should they look at evaluating those systems and the impact it's having on their patients? What's their gold standard?
I would say that Kaiser is the organization that's done the best job with this, at least from my perspective, and they've really done some terrific work. I admire the work done by Gabriela Escobar and Vinnie Liu. One example was a study that they did that looked at patients with sepsis, and they showed a substantial mortality reduction when providers were given earlier warnings. They've also done things like look at the decision about the child who might have sepsis in the emergency room, and they've showed that if you give people decision support about that, you get much better care. A big part of being successful in doing this is giving the information to the right provider at the right time in a way that enables them to make the right decision. So they're one leading entity in this area.
So one thing that they could consider, so an easy way for the bias to get baked into the algorithms is when there's just a small group of people developing the models and a small group of people evaluating the models. It turns out that, so for Mimic, we have 25,000 users. Each one is like QAing the codes, QAing the analysis. You're more likely to find the problems, and you're more likely to be able to mitigate any flaws in your model. So it's really pleading to the organizations that you need to allow your data to be shared to a much larger group of investigators. And of course, this is a problem for academics. Like most of academia does not have access to large, diverse data sets. You have to pay some companies $30,000 just so you can build models. And I think that that is a dangerous model to have. I think that is a perfect recipe to allow the magnification of the disparities that we have now from the model. So we're always pushing for data diplomacy and trying to advocate for data sharing. I think that's one way that organizations should really consider. And I'm really glad that the NIH has all these initiatives that promote data sharing to a larger research community, the Bridge to AI initiative, the Aim Ahead initiative. So hopefully that will also convince those who are in industry as well as those who are leading healthcare systems that this is the way to go. Getting that data into the hands of as many experiences, as many perspectives, as many expertise is really the best way forward.
Yeah, in addition to that, I want to add that there are frameworks that can help with and open source tools that can help with looking at bias. I mean, at least beginning there. So IBM, for example, offers an AI Fairness 360, which is an open source and comprehensive toolkit, both for detection and elimination of bias in machine learning models. And it has like over 70 fairness metrics that can help detect bias. It also includes 10 algorithms that can help eliminate bias if you found one. Some others are using crowdsourcing. You know, these are used to detect and mitigate bias as well, but sometimes you need tools for specific applications. So like Microsoft researchers are using crowdsourcing. That's another way that you can help detect. But the Chicago booth has published, I think the Center for Applied Artificial Intelligence has published sort of a algorithmic bias playbook. I think that's a good framework that can also be used. And it's Zayat Obermeyer is one of the co-authors on that. So there are certainly some tools to rely on in open source. In the meantime.
And I just wanted to take off from what Leo said about making data available. Some other countries have done a really great job of this. I have done some work with Scotland, and they have combined a number of data sets in ways that make it much easier for organizations to get the kind of improvement that Leo is talking about. And hopefully we as a country will do some similar things. We're a lot bigger than they are. They have several million people. We have several hundred million, and that makes it more complicated.
In our last round robin here, I'm going to ask for you to think big and maybe have this be your final call to action on this panel. If you had a magic wand, what would you fix either in the past or magically resolve now to both effectively and equitably harness AI in healthcare? Irene, I'll start with you.
Yeah, I can start quickly. I think we need to fix the way in which our science is conducted. It needs to be inclusive. How science is interpreted, and ensure that we are funding, equitable, inclusive trials. And also we need to consider how we can, our own human biases, and ensure that there's data empathy and compassionate care for everyone.
Leo?
That's my magic.
No, I mean, everyone is going to say that we need a better healthcare system, but that's not going to happen anytime soon. So in the meantime, I think we can do a better job of building capacity across different demographics. So as I said, I mentioned the Aim Ahead, where they're really trying to make sure that there are more researchers representing populations that are typically not represented in the research community. I think that is doable. I would plead to the funding organizations that perhaps you shouldn't keep funding institutions like MIT and really promote partnership between community college and universities with strong track record of research. Use this opportunity as a mentoring program, because I think that would definitely move the needle. We won't be able to fix this with the same academic pecking order that we have now, where we have a very homogeneous way of thinking, and we need to bring in more perspectives, more experiences, as we have discussed during this panel discussion.
Great. David?
I'll go in a different direction. I think we need to move a little faster than we have towards accountable care, which would help align our interests in many ways. And we should be moving towards learning healthcare systems. If we're going to get towards really becoming learning healthcare systems, it would require, having access to data in the way that Leo described.
Wonderful. Well, hopefully we all get our magic wands here. That brings us to the close of this panel. Thank you again to Irene, David, and Leo for your participation, and to the audience for your questions. Just a reminder that the video from today will be posted to the Hariri Institute YouTube channel later this week.